Welcome everybody to the workshop first tier discussion session. And just before I hand this off to Dr. Mack, I just wanted to let everybody know that just to make sure that you keep your microphones muted while Dr. Mack is doing his presentation. And at the end, if you have any questions or anything like any comments, to please raise your hand and then we will take them in order. The other option is to put it in the Q&A, and I will monitor the Q&A and let Dr. Mack know if there's any questions in there that he can address. So with that, I will pass it on to you, Dr. Mack.
Great, thanks a lot, Tracy. Welcome everybody, and so this is tier 1. Hopefully everyone here is for the right tier. Tiers 2 and tiers 3 are happening top of every hour today, but they are sort of separate Teams links for anyone who's participating in multiple tiers. Once we get through all the questions and discussion, we'll just end this sort of team session, and you can just join the link for the next one at the top of each hour. Before I get started, I just want to make a double check that everyone can see my slides okay. I think Tracy, you said they were displaying all right?
Yep, I can see them, no problem.
Perfect. And just by way of introductions, my name is Jonathan Mack. I'm a hematologist and physician with Canadian Blood Services, and work in the neural lab as one of the medical officers. My slides are not advancing. There we go. Before I get started, I just wanted to make sure to acknowledge all the individuals that have put in time and effort putting together the workshops for this afternoon. This is the first year that we've done the wet workshop, I think since COVID, I want to say. It's certainly the first time that I've helped to organize it. And it wouldn't have been possible without the help of the individuals on the screen here. So Tracy Cameron, Valerie Rayom, Sheena Sherman, who have helped on the ORBCoN side with making sure all the registrations and email communications were set up and all that sort of thing. And then on the neural and CBS side, several individuals who've helped with question development and all of the time and effort spent creating the samples that we sent out, packing them into boxes, sending them out, making sure that our testing was what we think it is. So that's Jacqueline Cote, Tammy Eisen, Lise Kemp, Carmela, and Tony Lynn. So a big thank you to all of them for helping to make this afternoon's activities possible. So with that, I think we'll get right into it. Meant to be sort of a learning session, not so much as a presentation. So to help facilitate some of the discussion at the end, if you do have questions about anything, do please put them in the chat, and if we have time to answer them as we're going through each question, we'll try to. Tracy, if you get questions that are relevant to each question, just you can stop and interrupt me, and we'll try to stay on time. So for case 1, I think most of you would have received the sample for this. There were a few people who received 2 samples in error, but should have been a red cell sample and a plasma sample from this patient, who was a 24-year-old male who was being seen in the ER trauma bay after a motor vehicle collision. Resuscitation was initiated en route to hospital via air ambulance, and the sample that we have sent out was what the transfusion medicine lab received from the trauma team once the patient arrived to the ER. So I've highlighted a few things here in the stem that are relevant, I think, from a transfusion perspective. It's a male patient and he's relatively young. It is a trauma, and that the resuscitation was initiated en route. So potential that patient had received blood products, depending on which part of the country you're in. And the sample was sent on arrival to the ER. So again, sort of emphasizing that there's a possibility of some transfusions happening before the patient actually got to us. So first question is just, what is the patient's forward ABO grouping? So this is sort of what are you seeing in the test tube? We had 10 respondents, 25% overall, 13 respondents, it's a little bit over, just about 30% of people answering mixed field for this question. You can see some of the other responses in this word map on the screen. So some that are not totally in line with the ABO grouping. So I'm not sure what the interpretation was for some of them, but most people getting mixed field, which was the expected answer. So what we were anticipating people to get with this sample was mixed field with the A typing and negative with the B typing, making it indeterminate because of the mixed field. So that's what we were expecting. Question 2 is, what is the patient's reverse ABO grouping? And so list of some of the answers that we got here. 28% answered AB for this question, which was a bit surprising on our end. The expected answer was group A, although weak anti-B was a possible answer. The sample was, two samples were created just by mixing some group O cells with the group A cell sample, and nothing was done to the plasma sample from the group A patient. So it was really an A plasma sample. But weak B might have been possible, I think, with some of the plasma dilution from the group O. So that's what we were expecting on the back type. So on to the questions. Which of the following would not explain the observed results? So again, looking at this mixed field on the front type and group A typing on the back type. The options here were ABO subgroup, a chimeric recipient, stem cell transplanter twins, a recipient of ABO compatible red cells, or a recipient of recent transfusion of ABO compatible plasma. In terms of responses that we had, a bit of a mix between options A, C, and D. So not too many people that can get a chimeric recipient was not possible. And this is just emphasizing that not was the keyword here. So of these, the expected answer didn't highlight for some reason. The most appropriate answers or expected answer here would have been recent transfusion of ABO compatible plasma. Again, this is with the expectation that we're having mixed field on the front and A typing on the back. And the rationale for that, if we go through our workflow for working up an ABO discrepancy, is first determining whether it's a red cell issue or a serum issue, if we can. And within the serum issue, if we're looking at, or within the red cell issue, if we have mixed field testing, RBC transfusion, stem cell transplant recipient, fetal-maternal hemorrhage, twin-twin chimerism, ABO subgroups, and certain types of malignancies can all be associated with mixed field typing. So if we go back to our options, you can see that plasma transfusion is the one that wouldn't explain that mixed field typing. And again, kind of makes sense if you have plasma that's given, you shouldn't really be influencing what the RBC phenotyping is. So that's the best answer there. Question 2 is, which of the following would be most appropriate if the red blood cells were requested for transfusion and it's an urgent situation? So again, for this patient, so option 1 was recommend transfusion be avoided until additional testing can be completed. Issue group A units, issue group A negative, A positive, A negative, or group O negative units. In terms of responses here, most people responding D, issuing group O negative units, which was the expected answer. And this is a patient who we don't have a determined ABO type for. And so if it's an urgent situation, we're not going to recommend that they avoid transfusion. If it's a life and death situation, we want to make sure they're supported appropriately. And until we can determine what the blood group type of the patient is, obviously group O as universal would be appropriate. If O negative or O positive was an option included, that would probably be a better answer than O negative, given that it's a 24-year-old male. But we didn't include that as an answer. So O negative is the best among the options here. We wouldn't want to be giving group specific unless we knew that he was really group A. Next question is, only one prior ABO typing was available on this patient's record. Which of the following is most appropriate? So blood products that are compatible with the prior ABO group should be issued. So if we know a prior historical type, we can issue according to that historical type. Group O red cells and AB plasma should be issued until a second ABO typing can be confirmed. So waiting until we get a confirmation of the typing currently. Requesting another sample for testing, so asking the team to send another sample so we can do the confirmation, or both B and C. In terms of responses that we had B and C being the most popular answer. A few people thinking we could issue according to the ABO group that we had historically, and some recommending just answer B, giving group O cells and AB plasma until we had the second confirmation. I'd say that the best answer or expected answer that we have here, the suggested one, would be just B, not B and C. Although I think we can understand the thinking behind requesting the other sample for testing. A few asterisks on there because we left it a bit open and weren't specific about when the sample for testing should be requested. I think we kind of intended people to think we'd be asking for it right away, which is why B and C weren't the favorite answer. But maybe I'll come back to that. I think, in terms of kind of the standard and the CSTM standards that guide this, if we're going to be issuing non-group O red cells, as you see there in the standard, the ABO typing has to be determined twice, including on the current sample. So even though we have that historical type, because we don't have confirmation on our current typing, we can't be issuing ABO specific products. Group answer C, I think the reason why that's not a great answer is we have mixed field testing. There's a possibility of transfusion in this patient. So if we're asking for a repeat sample, we're probably just going to be getting mixed field testing again. I think that's why B was the favorite answer, but I can understand why C would be included in there. And so B and C is, I think, a reasonable answer as well. Next question is the transfusion history is obtained, and in fact, the patient had never been transfused. So with that information, which of the following could explain the findings? So this kind of changes our thinking on things potentially. The options here would be an active cancer, low avidity ABO isohemagglutinins, cold reacting autoantibodies, or a mislabeled patient sample. Again, just to go back to the original findings, we were getting the mixed field typing on the forward typing, and group A typing on the back typing was what we were expecting. So in terms of responses here, it was relatively split between active cancer and a low avidity ABO isohemagglutinins. In terms of the expected answer that we wanted suggested was the active cancer. I think the understandable that we would have some people thinking the low avidity ABO isohemagglutinin might be there if you were getting that weak B typing and not picking up the mixed field. But this wouldn't explain the mixed field typing at all. So A is really kind of the best answer of the ones that are available here. If we go back to our ABO discrepancies and looking at our list of mixed field possibilities, malignancies are in there as one of the differentials that we would consider. So that's why that's the sort of favored answer. Why this happens is that in certain types of malignancies, the genes controlling ABO expression can be modified. So particularly in certain types of myeloid hematologic malignancies. And those modifications can then be influencing what the ABO expression is on the red cells, which can then lead to some of the mixed field typing. Cold reacting autoantibodies can cause interference. Obviously, with the ABO front and back typing, it's usually a back type issue. Sometimes a front type issue, but not so much a mixed field on the front type as much as it might cause unexpected reactions there. And then a mislabeled patient sample could give you a misleading or an erroneous ABO typing compared with the historical type, but really shouldn't be giving us a mixed field type result on the front typing. So that's why those answers aren't as good. So which of the following cancers would be least likely to explain the findings? In terms of responses here, myelodysplastic syndrome, acute leukemia, B-cell lymphoma, or a gastric cancer were the options. And this one was relatively split among them. Gonna emphasis on the word least likely, with the suggested answer here being gastric cancer. So rationale behind this one, I think, as I mentioned in the earlier question, myeloid malignancies are frequently associated with the loss of ABH expression. So there's some a paper there referred to that nicely goes through some of the examples of this and some of the mechanisms behind it. But a lot of it has to do with epigenetic changes on the red cells, where the AB enzyme production is really hampered by in the malignant cells, and that results in the loss of those those enzymes and subsequently loss of AB expression, making it so that makes MDS and acute leukemia likely to cause it. So not a good answer in this question. And then between B-cell lymphomas and gastric cancers, a little tricky. B-cell lymphomas not really commonly associated with modifications of antigen expression, but they can cause hypergammaglobulinemia, so high IgM levels in certain types of B-cell lymphomas, which can subsequently lead to rouleau, which can cause mixed field typing errors. And the cold autoantibodies that are produced in some types of B-cell lymphomas can interfere with forward and reverse typing. Not typically mixed field in those cases, but really kind of the rouleau that we're looking for that might be explaining it. Gastric cancers, interestingly, have been associated with certain types of ABO typing issues. Acquired B phenomenons associated with a lot of intestinal cancers, including gastric cancer. And that's related to risk of bacterial infections, which can then modify A enzymes into an acquired B phenotype. So it can lead an A patient to be a B looking on the front type, but not a mixed field type picture. So gastric cancer would be an explanation for an ABO discrepancy, but not the type of discrepancy we're seeing in this case. Just to mention there again about some excess soluble AB substance that's observed in certain types of cancers, including gastric and pancreatic cancers, which can cause issues with our front typing, but usually that presents as a negative a negative typing in an otherwise expected positive typing due to neutralization of the typing reagent because of that excess soluble AB substance. So again, there are some interferences that can happen in the front typing with gastric cancers and other intestinal cancers, but not the mixed field typing that we're seeing in this question. So that's why that's the suggested answer. Next question was, what is the best initial approach for investigating a patient with a suspected ABO subgroup? So our options here were ABO genotyping, which most people answered, ABO typing of family members. One person answered that, so DTT treatment of patient plasma, or DTT treatment of, so that should be patient RBCs, not plasma, just an error on option D there on my slides. So most people here getting the right answer, the right suggested answer, which was ABO genotyping. So the ABO subgroups, we'll have a couple tables summarizing what they are and serologically how they might appear. In terms of DTT treatment, this can be a useful technique for helping to resolve some serologic mysteries. DTT is dithiothrietol, and it works in two ways. It can affect antibodies in the plasma by destroying IgM through dissolving their disulfide bonds. So it can knock out IgM antibodies and be useful for treating plasma samples if we're worried about an IgM interfering with some testing results. And it can also be used to treat red cells, and it removes KEL, LW, Lutherin, Cartwright, and Dombrock antigens. So can be useful reagents, but for a suspected ABO subgroup, not really all that helpful. Between ABO genotyping and ABO typing of family members, the genotyping is going to be the best initial investigation because that's really going to get to the answer on that patient. ABO typing of family members might give you a sense that there could be some kind of a hereditary subgroup that's in the family, but it's not really going to help you resolve really what the answer that you're looking for, which is does the patient you're testing have a subgroup. In terms of serology and why serology can be a little bit why serology is not as good as the genotyping is if you look at some of the A subgroups summarized here, you can see on the table that there's some variability in what we see, but a lot of the subgroups could have positive reactions, could have negative reactions. Some AELs, for example, have reverse anti-A, may or may not have anti-A1. So there's a lot of variability, and you're really not going to be able to get to a definitive answer. You might be able to suspect a subgroup type based on your serology, but genotyping is really going to answer the question with the most certainty. That's just a summary of some of the B subgroups that we see as well, which is again, just sort of emphasizing that there's a lot of heterogeneity and not all the subgroups behave the same. So even patients with the same subgroup, there's a bit of variability in terms of what we're expecting for results. So not going to be as helpful as genotyping. All right, so which of the following interpretations for this forward and reverse typing that's summarized below is most likely if anti-A is recovered following adsorption elution procedures with red cells from a patient with those results? So what are we seeing on this, the front and back type results? We're seeing on the front type, the patient's typing like an O, with no reactions with anti-A and no reactions with anti-B. And on the back type, the patient is typing like A with no reaction with A1 cells, but reactions with a B cell. So our options here are A2, which was shared the most common answer, an AEL. Shared it with the AEL, so those two were the top two answers. Some votes for para-Bombay. Group O patient transfused B plasma, and no one said thinking it was all of the above. In terms of the expected answer here, so again, just a forward on the O and reverse was an A. So if we go back to our table of ABO discrepancies, this could be a problem of the red cells. If the back type is kind of the truth, then the front type is missing the expected A. So we could have a weak or missing front type, which could be due to an ABO subgroup, malignancy, transfusion, stem cell transplant, or excess soluble AB. On the flip side, the back type might be the one that's giving us the problem, and the front type is really the truth. So if that's the case, then it's could be from a weak or missing antigen due to extreme of age. So really young people or really old people may not be expressing their anti-A or anti-B. Could be due to ABO subgroup, hypogammaglobulinemia, or stem cell transplant. So between the two, if we look at what's sort of the Venn diagram overlap, the ABO subgroup would kind of help to explain both of them. So that's really kind of the suggested answer here. And among the two subgroups that we have, A2 would be expected to give a front type that's group A, because A2s will react with anti-A, anti-sera. The monoclonal anti-sera will agglutinate A2 cells. So you expect a positive reaction with the A, not forwarding as an O. And it would forward as a negative with the B typing. And where the problem that we see with a lot of A2s is on the back type, where we're having an unexpected A1 antibody. So we have a positive with the A1 and a positive with the B cell. So that's not what we're seeing here. So an A2 really doesn't fit this kind of a picture. Para-Bombay, so this is a phenomenon where we have soluble H. So it's a secretor who is able to secrete H substance, but doesn't produce H substance on their red cells. So they front as an O, their forward typing is group O because they're not making that H substance, can't express A or B on their red cells. But they can make an anti-H. So on the back type, they can have they react with A1 cells and B cells. So you expect sort of an O on the front and O on the back typing. It's where we see the screen that's going to be reacting with all of our O cells, but not with the autocontrol where we pick that up. So this kind of pattern where they're fronting as an O, but reverse typing as an A patient really wouldn't fit with a para-Bombay. And then with a group O patient, if they're transfused plasma, their front type would be a group O. Their back type, though, we wouldn't expect anti-B. We'd expect there to be anti-A if they were transfused B plasma, which is not what we're seeing here. So that one doesn't make sense as an answer. So that leaves us with AEL. So AEL is an A subgroup. It results from very weakened expression of the A antigen in a person who has the A gene. So they make the enzyme, but the enzyme is just reduced in its function to the point that they're only producing about 1,000th of the A antigen that's expressed on a normal A1 cell. And so often their forward typing is like an O patient. But if we do an adsorption elution with our anti-A on the front typing, those red cells will absorb the anti-A, and it can then subsequently be eluted off. So you can pick up that the patient is A by doing an adsorption elution procedure and picking up the anti-A that's eluted off. And they'll most of the time reverse as a group O with anti-A1 and anti-B, although not all AELs have anti-A1, so they can back as a standard sort of A type patient without anti-A1. So that's the best answer for this question. All right, so for which of the following scenarios would a group A red cells from your routine inventory, so presumably an A1 red cell, be least appropriate? Our options here were a group A2 patient with anti-A1 detectable at only 4 degrees, by a few people, but not many. A group AB patient, group A2 patient without anti-A1 detectable, or a group A2 patient with anti-A1 detectable at room temperature. That was the response picked by most. That's good. That was the expected answer. don't think we have to go into too many details in here, but if we have an A2 patient, if they don't have an anti-A1 that's reactive at room or body temperature, reasonable to provide off-the-shelf A1 cells. And where we worry about transfusing the A1 cells to an A2 patient really is when they're starting to have reactivity of their A1 at 37 degrees or at room temperature. So among these options here, that patient with the room temperature reacting antibody would be the one you'd be the most worried about giving A1 cells to. A group AB patient could get A cells, no problem. Those are going to be compatible with their type. And a group A2 patient who has no anti-A1 that's detectable, you arguably could give A1 cells to without too much of a concern. Right, so patient in question 9, which was the AEL patient, whose results are summarized below again, just for a reminder. Question is, which of the following products would be recommended for transfusion for that patient? So our options here were A, red cells, picked by not many people, O red cells and A plasma, A red cells and A plasma, or O red cells and AB plasma. So most people were picking the O red cells and AB plasma. A few people picking the O red cells and A plasma. Suggested answer here would be A red cells and A plasma. Again, this is the AEL patient without any anti-A1 detectable on their back type. So if we're wanting to transfuse this patient, assuming that we've confirmed their status and there's no doubts about needing a confirmatory sample, et cetera, we could actually safely transfuse an AEL A red cells, as long as they don't have the detectable anti-A1. So for most AEL patients, you're going to see a detectable anti-A1, and O red cells would be the best answer. But for this particular patient, where we're not seeing any anti-A1 in our back type, A red cells would be an okay option and totally fine to do. A plasma would be okay. It's compatible. Again, even though they're typing as an O, they actually do have A antigen on their red cells, just at very, very low levels. So A plasma would not be incompatible at all with them. It's the AB plasma that would be incompatible. So those two are the ones that we want to avoid for sure. I put the 3 asterisks on the group O red cells because I think that's a reasonable answer. But if we're trying to really stick to group specific, the A red cells would be fine to give to an AEL as long as they don't have an anti-A1. So if a group A patient is transfused emergency leukoreduced whole blood, which of the following would be expected? We have a few different options here, and I'll just put up the answers. I think there's a relative homogeneity on responses here. So someone's given leukoreduced whole blood, which of the following would be expected? So they're a group A patient. So their anti-A could be 4+ with nothing on the B, and on the back type, 1+ A1 and 4+ with the B cells. So having a little bit of A1 reactivity. An anti-A that's mixed field with nothing with anti-B on the front type, and on the back type, some weak reactivity with the A1 cell and strong reactivity with the B cell. Anti-A that's not detectable on the front type, no detectable anti-B on the front type, and strong reactivity with both the A1 and AB cells on the back type, so having anti-A and anti-B at quite high strengths, and then anti-A mixed field, anti-B not detectable, and strong reactions with both A and B cells on the back type. So the correct answer here, most people got, this would be B. So we'd be expecting, because this is a group A patient receiving leukoreduced whole blood in an emergency setting, the leukoreduced whole blood not available in Canada currently for most civilian uses, although there are some trials that are starting, so we might start to see it showing up. And it's going to be group O that's used in emergency situations, because we won't have the patient's ABO type identified yet. So that is going to mean that there's going to be ORBCs, which could result in mixed field in the non-O recipients, such as this patient who's group A. But the plasma that's in there is going to be group O plasma, and so it's going to be containing anti-A and anti-B. And so that's going to influence our back type. Not to the extent that we'd be seeing a 4+ typing like we see in anti-A, or sorry, in answer D, where the typing is 4+. We're not going to see that kind of strength, but it'll be a weak typing that we would expect to see from the plasma that's given, that O plasma, and so that's why answer B is the favored answer here. just a bit of information on leuke-reduced whole blood. It is produced with O donors, but the donors have been screened for their titer, their anti-A, anti-B, and only low titer donors are going to be used for the production of that whole blood. So that minimizes the risk of hemolysis in a patient who's a non-group O patient. But I won't say too much more about blood than that. So with that, I guess that ends all the questions. They didn't go through them too quickly, and this would just leave it there and open it up for any questions or discussion points on any of the answers. I don't know if Tracy, if there's anything coming up.
Yeah, so there's nothing so far on the Q&A, and yeah, nothing on the chat. So if you guys have any questions or, want anything explained further, just either raise your hand and we will get you in order, or if you're not comfortable, then we'll put it in the chat. And yes, it is being recorded, and we will make it available in a couple of days. Oh, there's a cute question. Hold on. Is whole blood an option for transfusion?
Right. So currently, whole blood is not available for routine non-military use in Canada. It has been Health Canada approved. So CBS does have processes to manufacture it, but it's being used for military use exclusively at the moment. There are some trials that are being planned in the Canadian setting. One that is going to be Ontario based. That we're anticipating in the next few months. So it might be something that larger hospitals might see showing up in some patients that are treated as part of that trial. But outside of a clinical trial setting at the moment, it's not available in Canada.
In question 11, are we to assume that the AEL subtype has been confirmed with genotyping?
I think for simplicity purposes, sure, we could say it's assumed. I mean, I don't know that you'd have to. If you had the adsorption elution that was that you're confident on, and you know that there's detectable anti-A, you've confirmed with the adsorption elution that anti-A is, or that A antigen is present on those red cells, you'd still be okay to give the A red cells and the A plasma. But I guess can make that clearer if we ever think about that for future questions down the road to make it really, really clear. Yeah. Did that answer the question? Hopefully that answers the question.
All right. Yeah. Terry says, thanks for answering the question. Anybody have any other questions or comments or something that you just want clear? Okay, hold on. Are there areas where resuscitation includes transfusion en route?
Yeah, great question. So there are a few areas. So it's Orange is the Ontario. So just kind of speaking in the Ontario context, Orange is the provincial air ambulance system, and they do have a program for en route, like pre-hospital transfusion, that currently uses red cells only, and that's out of a couple bases, I think, in Thunder Bay and in Toronto. There's I know some discussions around it. I mean, the Orange program, I believe, is looking to expand that program across the province. But so that does exist in Ontario, and in other provinces in Canada, out in BC and in Alberta, they do have pre-hospital, and Manitoba as well. They have pre-hospital transfusion for the air ambulance services in addition. So there are several areas in Canada that provide pre-hospital transfusions with red cells for most of them. I can't speak outside of Ontario confidently, but I think out in Alberta, I want to say there's plasma available as well, but not in Ontario currently, but that's something that's being developed.
I think it's also being Orange is working with the Timmins group too to get it set up there.
Perfect. I guess if there's no other questions,
Oh, I think there's someone. Oh, yeah,
is there?
sorry. Laura's got her hand up. So go
Sorry,
ahead, Laura.
I'm super interested in this whole blood thing, so I'm sorry I keep going back to that. What are the advantages of whole blood, and or is it? I'm going back to the old days where my uncle actually passed away because of a whole blood transfusion, like back in the 60s, and obviously it wasn't tested for any of the viruses that we test for now. But I guess what is the advantage? What's the thought of change to whole blood versus our cells and plasma separately? Is it just trauma patients that it has an advantage for? Is there like what is the process of thought?
Yeah, so it's a practice that's been sort of in evolution. Obviously, like the transfusion medicine as a field sort of started with whole blood products, and then in the 50s and 60s, as the ability to make components became developed, and you could sort of get more bang for your buck with each donation by making a platelet or a red cell and being more targeted with how you're transfusing things. The practice shifted really away from whole blood towards component therapies. And then I think in the Canadian context, when it became a requirement to have leukoreduction for all of our products, that was really kind of what ended the use of whole blood, because we didn't have any filters that could remove the white blood cells but preserve the platelets. And so that really kind of led to the shift towards a component inventory completely. In the last 10 years or so, there's been a lot of renewed interest in whole blood as a product. And a lot of this has been driven by trauma and military use, kind of analogous to some of the discussions that have occurred around balanced resuscitation with the 1-to-1-to-1 or the 1-to-1-to-2 kind of discussions that have gone on. And there's been at least one big trial that was done in the U.S. addressing that question. So a lot of it kind of really stems from that. And so the idea and the benefit in theory about it is that you're giving back really a balanced resuscitation product. So rather than trying to recreate that, which some trauma or massive hemorrhage protocols will do with a 1-to-1-to-1 style or a 1-to-1-to-2 style, you're giving everything in a balanced ratio in the bag in one transfusion. So logistically, there's a lot of I think a lot of strong arguments to make that it's easier. I think on the blood bank side, as you're preparing your boxes, rather than having to prepare multiple bags, you're just sending out one bag of whole blood and it's got everything in it. From a transfusion, bedside kind of perspective, you're not having to scan and deal with 3 different products. It's just one product to check and go. So much simpler to hang. Just the one IV that's going and all the products going in at once. But it isn't without some downsides. I think if you look at the patient level, it's you're committing to giving a specific blood type, rather than components where you can give O cells and AB plasma, which are going to be universally compatible. There's going to have to be an incompatibility unless you're giving group specific whole blood. So the practice has developed to use group O whole blood because those red cells are going to be universally compatible, and that's more important, it seems, than giving the compatible plasma. But there's a bit of a risk of a hemolytic reaction with that. There are mitigation strategies that have been introduced. So, like I mentioned earlier, like using only low titer anti-A, anti-B donors to produce the whole blood as a way of reducing it, and also not transfusing unlimited volumes of whole blood to patients who are being resuscitated, but capping the number of units that are being given, again, just to kind of minimize how much anti-A and anti-B exposure they have. And from data that we have from the US, where whole blood's being used and studied for 7 to 10 years now, that seems to be like a safe practice without a lot of safety concerns for patients. So it's I think an evolving kind of field, the whole blood, and where it should be used in. I guess in response, or the specific answer to your question is a lot of it is logistics and the theoretical benefit of giving a more balanced product. But what we don't have currently is a lot of solid data that it actually is better from a clinical outcomes point of view. That data is not shown in very high quality studies yet. There's quite a few studies that are looking at it, but the main interest is in sort of pre-hospital austere settings where it might be difficult to maintain an inventory of products. If you have a frozen product like plasma, you need to have a cold chain. It has to be thawed. So there's some delays that happen there. platelet inventory is a little bit more limited. Just in terms of the shelf life, we have 7 days in Canada for our platelets, whereas the whole blood product is a 21-day shelf life. So there's some benefits there. So I think the main interest areas are really those austere settings where you don't have access to traditional kind of blood bank supports, I guess, in terms of capacity to store, thaw, et cetera, and maybe limited in how much inventory you can stock. And then also in the trauma setting where it's kind of that balanced and providing products very quickly.
Thank you. That's exactly kind of where my thought process went, is like, okay, platelets are only good for 7 days. What is the expiry date on whole blood? As well as, like, is there proven coagulation factor degradation over, or does it stay better in the whole blood?
Yeah, no, they do. They definitely do degrade over time, and so there are changes that happen to certain the labile clotting factors decrease over time. The platelets do decrease over time as well, and so whether or not it actually is I think a superior or even a non-inferior product haven't really clearly been established in a lot of prospective trials, and that's a lot of that is behind the CBS approach to having it reserved for military use. Largely driven by the sort of logistical and environmental challenges that exist with maintaining a blood product inventory for emergency situations, and not wanting to commit to creating this new product that's going to have an impact on the national inventory potentially, until we know clearly that it, how it, what benefits it offers clinically, and if there's really hard outcomes that we can establish that are improved through its use.
All right.
Thank you.
Okay, so the next question we have is, where can you find the flow charts that you showed in your presentation?
Oh, good question. I made that one myself. I don't know if I could probably share that slide with Tracy and she can email it out if people are interested in it.
Yeah, we can do that. We can do that. Okay. Yeah. So we'll share it with everybody. And then I think this will have to be our last question, so that you guys have some time to have a bio break before jumping on to the next session. So could Sorlin treated negate the issue of leukoreducing whole blood without losing platelets? Thinking more so for a massive trauma situation as opposed to regular use.
So could Sorlin use? In theory, it could. I think the limitation we have currently is the well, actually, no, I don't know that it could. So there's the Sorlin treatment isn't really a replacement for the leukoreduction, because leukoreduction, the benefit of leukoreducing is really to remove the HLA, HPA exposure that happens through the white cells. And so if you Sorlin treat, you're not really addressing that HLA antigen exposure that could happen. The Sorlin treatment pathogen reduction is really about trying to knock out any pathogens, microbial pathogens that are in the unit of blood, but not about modifying the HLA antigen exposure. So they're kind of achieving two different things. So I think in terms of kind of replacing one with the other, that wouldn't be a solution. The other limitation is just technically right now there aren't any technologies that exist that can successfully pathogen reduce red cell products. So we've shifted to pathogen reduce, or we're shifting to pathogen reduce platelets for our platelet inventory nationally. But there aren't any equivalent technologies that are as effective for pathogen reducing red cells. And my understanding of that is it has to do a little bit with the absorption of the UV and how the red cells interfere with that. But I think ultimately they're kind of achieving two different things. So it wouldn't really be a replacement one for the other.
Okay, awesome. All right. So thank you very much, Dr. Mack, for doing the presentation for Tier 1 session. Just to let everybody know that we will be sending out certificates for those that have attended today and for those that have submitted their results into us, so that you get credited for an hour for each tier and for doing the actual testing and then for attending. So just stay tuned to your emails in the next week or so and we'll have them sent out. We just have to kind of go through and culminate all the hours for everybody. And with that, I don't know, Dr. Mack, if there's anything else you want to say before we close off?
No, just again, a big thank you to you, Tracy, for your help with putting the workshop together, for everybody for participating, and for all the support from Neural and ORBCoN. I think it's really a big, huge group effort and a lot of stuff that went into this behind the scenes to make it successful. So thanks to everybody, Neural and ORBCoN.
All right. Okay. Thank you. All right. So we will see probably most of you back for the next session. But if not, thanks again for participating, and hopefully we'll be able to do this again next year. All right.
Thanks, everyone. Bye-bye.
Okay. Thanks. Take care, everyone.